Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Thank you for joining us for Rethinking Stroke Prevention, addressing the unmet needs in antithrombotic therapy. My name is Manesh Patel. I'm a cardiologist at Duke University and chief of our division of cardiology, and I'm joined by friend and colleague, Dr. Gibson, who will have introduce himself.
Hey, I'm Mike Gibson. I'm an interventional cardiologist, a professor of medicine at Harvard Medical School, clinical trialist, and I run a research institute up here called the Baim Institute.
Thanks for joining me, Mike. This will be an interesting conversation. And our learning objectives today are that at the end of this learning event, you hopefully will have the following abilities. One is to recognize the limitations of the current anticoagulation therapies in stroke prevention, including the risk of major bleeding and the impact on residual stroke risk on our patient outcomes. To be able to differentiate Factor XIa inhibition from traditional anticoagulant mechanisms by analyzing its safety profile, efficacy, and potential role for stroke prevention. We want you to evaluate the clinical trial data and the implications on Factor XI inhibition on both of those outcomes, and we'll walk through that. We also want you to apply clinical decision-making frameworks, which you likely use now, but will continue to use to identify appropriate patient populations that benefit from this potential new class of Factor XIa inhibitors based on stroke risk and bleeding risk and guideline recommendations. And finally, with all of that information, we hope that you integrate these emerging stroke prevention strategies, including Factor XIa inhibitors, into your evidence-based practice and treatment of patients to balance their efficacy and safety. So before we begin, I guess I just wanted to ask you, Mike, when you're taking care of patients with the risk for stroke, which challenge often shapes your treatment decisions? Is it bleeding risk, adherence, concerns around stroke risk, or is just overall safety something else? What drives you, Mike?
Manesh, that's kind of funny. It's a little bit like asking someone on a balance beam, are you more worried about falling off on the left or the right side? I think we're worried about falling off. We have to balance both of these. We're doing a pretty good job on the efficacy side. We've got some drugs that are pretty good in preventing stroke. Now we got to, though, worry more about making sure it's safe. And I think, I always talk about there is the number needed to treat, that's efficacy. There's the number needed to harm, that's safety. But there's ultimately NNB, number needed to blame. People are really risk adverse. They don't want to get blamed for a side effect like bleeding. That really drives a lot of our risk avoidance. So these days, I think we're a little more worried about falling off the beam based upon bleeding.
Yeah, I think it's a great perspective, Mike. And as we go into this conversation, we've spent a lot of time finding that, I'll call it Goldilocks period, where how do you figure out where the right balance is, as you've highlighted. And a lot of what we've done has gotten really specific at finding ways for prevention of stroke, which is great. But we certainly are thinking through now, how do we make that safer? Well, maybe I'll start us off here with the unmet need for stroke prevention and where we are. And it's not new information, but atrial fibrillation and stroke risks are underestimated. It's estimated by 2030 that atrial fibrillation will affect 12.1 million Americans, and AFib causes 1 in 7 strokes, which are typically, unfortunately, more severe and disabling, as they're often larger in that cardioembolic pathway to larger vessels. The risk factors for this have been well described, and we have a variety of scores and ways to think about this, but in general, they include people that are older in age, have high blood pressure or hypertension, heart failure, diabetes, a history of prior stroke, TIA, vascular disease, chronic kidney disease, female sex, and low increasing BMI. AF now is detected in multiple ways. We have a whole variety of wearables that I'm sure our clinicians engage in at times. It's also found 80% of the time the first episodes are asymptomatic, and these brief episodes do raise our short-term risk 4 to 5-fold, and the highest risk is often 5 to 10 days after it's first identified. This is a global disease. I often say that atrial fibrillation is the most common arrhythmia worldwide that is of significance, and unfortunately every 40 seconds someone has a stroke. in the United States, and every 3 minutes and 14 seconds, someone unfortunately passes away from a stroke. And so the burden of stroke in the United States is a persistent and daily challenge. We know that, according to the American Heart Association projections over the next 50 years, people will be increasing in age and they'll be having an increased risk of stroke. It's the leading cause of disability and the fifth leading cause of death in the United States. And often when we talk to our patients, it affects their cognition and their quality of life, and they think about stroke a lot because many patients, I'm sure, Mike, as you've seen in clinic, will say they do not want to have a stroke because they don't want to be a burden on their family, on society. And so these are real issues that we deal with, and balancing that with making sure they're able to take a therapy to prevent that is a common issue that we deal with. The incidence of this stroke, it should be important to think about, is that 62% of stroke is ischemic, 28% is intracranial hemorrhage, and 10% is subarachnoid hemorrhage. So when we think of stroke as a broad disabling effect, it's also valuable to think about stroke being in part sometimes ischemic and sometimes an hemorrhagic complication of a variety of things. And this is a nice, I guess, way for us to think through this, in that about 2/3 are ischemic and 1/3 are related, at least in some way, to hemorrhagic complications inside of the brain.
So Manesh, it's those bleeding strokes that are more disabling than the ischemic ones. And that's what keeps us wanting to fall off that side of the balance beam towards bleeding stroke. We don't want it.
You're right, Mike. And I would say, all of our advances in stroke prevention therapy have been more specific targeting of anticoagulation therapy that's actually reduced that bleeding side.
Right.
Even though we have overall stroke reduction, it seems that we're getting much, much better at reducing the bleeding side, while at least keeping some of that ischemic protection.
Right.
And so, that is the hope. And we'll show that, unfortunately, for our patients, there's continual toll of, as you just highlighted, the associated intracranial hemorrhage. The bleeding side into the brain is the deadliest and most disabling stroke, as you just highlighted. And, with vitamin K antagonists, it was occurring with warfarin 0.6% of the time annually, which sounds like a small number, except, as I like to say, it's bad interest. It compounds every year, and you have that risk continually in your life if you're on these therapies. Now, the DOACs, as we know them, had a reduction in 50% of this. And as I just highlighted, are the primary ways that these therapies, I think, beat warfarin and vitamin K antagonists on the stroke side by reducing that bleeding and reducing that intracranial hemorrhage by 0.1 to 0.2%. So they all had a significant reduction in ICH and fatal bleeding in the brain. And that eventually led to a reduction in ICH-associated mortality at 30 to 90 days. And these anticoagulants, often when they have a hematoma, lead to larger expansion and higher mortality. So the ability to have a more specific antithrombotic or anticoagulant was really important and made a role here. And the functional outcomes from people after ICH are quite important to recognize. That at 1 year, only 57% were able to be back to a functional work, and 67% at 2 years. So there's long-term and functional impairment to get back to work for these individuals. And the economic burden is not small, with a total cost, indirect, you can see in the $90 billion range. And this is expected by 2035 to be over $94 billion of direct cost, and the highest amount being, unfortunately, in our non-Hispanic, white, Black, and Hispanic population. So a lot of these individuals will be affected. Now, I won't go through this slide as it's quite dense, but the keys to this slide are that the challenges with existing anticoagulation, or the keys to this information about the challenges with existing anticoagulants, are that there's undertreatment. And despite, knowing that these new therapies are effective, there's large numbers of individuals, 15, 20, 30% of people, who are getting lower dose than what is at least prescribed or impacted, or not getting therapy at all. So undertreatment by not getting therapy, or underdosing by getting the inappropriately lowered therapy. And then there's the patient perspective, and patients who have identified that their concern is bleeding, and the bleeding often drives their thought process about the therapy. And then there's the impact of non-major bleeds. And here I think it's important to recognize that a global survey of over 3,000 oral anticoagulation users revealed that almost 29% paused or considered pausing therapy due to minor bleeding. Many have interactions where they have to go through a procedure, or have to have other things they're doing where they have to stop, or then don't come back onto therapy. So the impact of all of these things is that there's many people with chronic atrial fibrillation who have their decisions being affected by their concerns around the therapy and the risk of the therapy, and stopping the therapy, underdosing the therapy, or going on and off at periods because of these concerns. And so the challenges with our existing therapies for anticoagulation and safety and efficacy is that we know that anticoagulants are vital for reducing that risk of stroke that we discussed are quite debilitating for our individuals and our patients. Yet we know a third of those are these ICH or hemorrhagic events that can be quite debilitating, whereas 2/3 are ischemic. So we're like your balance beam, always balancing. Can we make sure we keep the ischemic stroke reduced while we work on the bleeding side to see if there's a better way to do that? Even with our newer therapies, or now not newer, but over the last 15 years, the direct-acting oral anticoagulants, we still have a 3 to 5% annual major bleeding risk. And the DOACs did reduce intracranial hemorrhage by 50% compared to vitamin K antagonists, but they still carry a 0.1 to 0.2% risk. Many patients, again, because of these concerns, remain undertreated. And, when we look into what does that look like in our world of current practice, in the Pinnacle registry, there's multiple registries, Garfield and others that people have done to see the effect. Less than 50% of some of the high-risk AF patients receive guideline-directed oral anticoagulant therapy. We've looked in the PCORI data sets. Others have looked at even today, in the last 4 to 5 years, there's still 30-40% of people that aren't getting oral anticoagulation therapy as identified by either getting the therapy prescribed or getting it at the dose that's most known to be effective. The suboptimal dose is linked to increased mortality and stroke, and it's likely observationally linked to increased mortality and stroke because doctors are very good at figuring out who looks sick or who is sick or who's at higher risk. And so when they identify people that are at higher risk, they're older, they look more frail, they dose reduce, and that dose reduction then does two things. One is it unfortunately does not provide the stroke protection, but it still exposes them to some of that potential bleeding risk, and we have a higher risk of mortality and stroke. And 1 in 3 patients have really poor adherence to DOACs, and so there's still an opportunity there if we had other therapies to work forward. 27% of these patients have missed at least a dose in the last 30 days, and that again increases your stroke risk by 30 to 40%. So with all of these thoughts together, it's a consideration that maybe a new pathway or inhibitors of a new pathway, the Factor XI pathway, which I know we're going to talk about, may provide safer, more targeted alternative therapies. It should be noted that major bleeding, as I just highlighted, one of the registries, Garfield registry, major bleeding is associated with higher mortality. Survival curves and evaluations of these registries have shown that after even a minor or clinically relevant non-major or major bleeding event at 1 year, there's significantly higher risk for bleeding. And that bleeding then also is associated with a mortality. So once you have that bleeding event, you have a higher mortality. You may have repeat bleeding events, so it's quite a risk for these individuals. And through multiple studies, we've seen that the risk factors for stroke, despite oral anticoagulation in our patients with atrial fibrillation remain. And maybe the strongest risk factor is a prior stroke or TIA, but permanent atrial fibrillation, antiplatelet use, prior MI, hypertension, some of the things we've discussed really identify those individuals that are at the highest risk or highest residual risk, as we know. And they're often the risk factors that we put the patients on the anticoagulation for the first place in atrial fibrillation. And, having a history of a stroke doesn't ever go away. We try to reduce that risk with anticoagulation, but having permanent atrial fibrillation certainly pushes it even higher. And when you have to use antiplatelets or if they have renal dysfunction, that goes higher even more. It is worth noting that, again, back to Garfield, that, the bleeding rates per 100 patient years, according to antithrombotic therapy, is notable for the fact that antiplatelets were commonly prescribed in our patients with DOACs. And once you prescribe DOACs and antiplatelets together, there's significantly more minor bleeding, and that minor bleeding drives a lot of the other things we happen. And then that minor bleeding does drive major bleeding and clinically relevant non-major bleeding. And we see that at baseline, that patients who have antiplatelet therapy and then patients who get that antiplatelet therapy on top of anticoagulants are quite at higher risk. And the highest risk patients are those newly diagnosed with atrial fibrillation. So I've stated in this and other forums that, we sometimes think, oh, well, these patients are stable. They are, but their stroke risk goes up. But sometimes in some of our data sets, we're identifying people that are, I'll call it responders. They don't bleed and they don't stroke on these therapies. And so we best identify and understand these therapies in newly diagnosed AF patients. So, I'll conclude by saying there is significantly an unmet need in stroke prevention. There's persistent gaps in care. Many patients remain undertreated, and there's a fear of bleeding. There's a safety efficacy trade-off, as you nicely highlighted, Mike, about the balance beam. We don't want to fall off on either side, but certainly we're spending more time thinking about bleeding because we are often seeing that as something that has got high variability and high opportunity to improve. And we have a promise of Factor XIa inhibition, at least a new pathway that might help us uncouple that antithrombotic efficacy, I'll call it, stopping bad clots, from the bleeding risk, which we may be able to do in our patients. And early trial phases show some results that might be important that we can talk about. Patients are certainly prioritizing stroke prevention, but they're scared of bleeding, as we've highlighted, and will often stop therapy. And the implications, I think, are that if there are safer alternatives, especially in the elderly, renal dysfunction, patients with prior bleed, or ICH, shared decision-making might allow opportunities for new therapies. So maybe I'll, just as I started, I'll sort of transition, Mike, as we transition to the burden, as we go to the next sort of section of things. When we think about the burden of AFib and exploring novel therapies, maybe, how do you feel about our current options? Where do you see the greatest paradigm for stroke prevention? Maybe in part some of the things we've already discussed.
Well, you said it well, Manesh. We have pretty good treatment in preventing ischemic stroke with warfarin, but the goal has really been to reduce bleeding, and the DOACs did a good job of reducing bleeding. They reduced the risk of ICH by half, and that in turn probably led to the reduction in mortality we see when you look at the whole class. So we're doing better, but we still have a lot of people who are very hesitant about the bleeding with the DOACs. So we still need to make some further improvements. And that's why I think many people are excited about this class.
Thanks, Mike. I think this has been a great discussion over the unmet need and sort of the opportunities that exist for our patients with atrial fibrillation, and that we're looking to have stroke prevention.
We hope you found this podcast useful and educational.